Hello, everybody. Welcome to today's ACL Deep Dive. I am Dr. Mica, a physical therapist in Seattle, Washington. So I'm here presenting to you at the Movement, Rehab, and Performance headquarters in Seattle, Washington. And we are going to take a deep dive today on graft options. So going in to the ins and outs, advantages and disadvantages of every graft option. And I'm here to answer any questions that you might have as well. I am not only a doctor of physical therapy, but I am also a strength and conditioning specialist and a three-peat ACLer myself. So I'm going to maybe put a little bit of insight into my options personally and see if that helps you. And if you have any questions at any point in time, feel free to chime in. Thank you for joining our ACL community. This is a community designed specifically for you. These were questions that were asked by many of our clients, and even seeing people online asking these questions. And we want to give an evidence-based answer for you guys and to really make sure that you understand what good care looks like. And if there's any other topic that you want to learn more about that is not already included in the roadmap, which I hope you've already checked out. If not, go ahead and check out that roadmap. It spells out every little detail that you should be looking for in your rehab to help you get back to the things that you love. If you don't see anything, just reach out to us, DM us, and we're happy to put evidence-based information out there for you. If you are feeling lost in your rehab too, that's another thing that we are here for. We do this for a living. We do this for you. We want you to make sure that you get back to everything that you deserve to be doing without any issue with your knee at all and without even having to think about your knee. So we offer remote coaching services, and if you are one that is navigating this ACL journey by yourself without any guidance, because this is not what you do, we are here to help. Or if you are feeling lost at all, we are also here to answer any questions that you might have. Okay, let's get on with it. Let's go through this ACL deep dive about graft options. Just a full disclosure, this is not medical advice. This is just evidence-based information out there to help you make a decision, an informed decision, because at the end of the day, you need to do what is best for you, okay? Nobody is going to tell you what you should do. At the end of the day, you just need to consider all your options and make an informed decision on what is best for you. Okay, so going through the graft selections, this is one of the major topics that a lot of people ask when they're sitting in front of their PT or even sitting in front of their surgeon, their selected surgeon, to figure out what options are best for them and things that we need to consider. So there's a lot of ins and outs of graft options, but I'm going to keep to like the very basic stuff. And if you need more information, we also have a deeper dive in our roadmap as well. So graft selections, there's no one size fits all for anybody. It all depends on what you are trying to get back to at the end of the day. So you need to take that into consideration. There are two things. There's an autograft, which is using your own tissue, or there's an allograft, which is using tissue from a cadaver or a donor. Within those two options, you could use the patellar tendon, you could use the hamstring tendon, the quad tendon, and for the donor part of things, sometimes they even use things like the tibialis anterior. It just all depends on your surgeon. Okay, so we are going to go through the allograft first. The allograft, remember, is donor tissue and or cadaver tissue. So this is not your own tissue. Typically, this type of graft option is best for people who are above 30 years old. Ideally, people who may be even closer to the 40-year-old range. These are people who are still active, but who don't really compete on a regular basis in higher level sports. So they might be your occasional, pick up soccer type of person, or pick up basketball, maybe they ski a couple times a year, things like that. But these are people who aren't yearning for that practice 2 or 3 hours a day, tournaments on the weekends, all of those things, okay? Now, the advantages of choosing an allograft or donor tissue is that it's an easier recovery early on because there is not trauma being taken, there's not trauma to have to take into consideration initially, just because you're not stealing from your own tissue. So it makes things a heck of a lot easier. So that early recovery process tends to be a lot smoother for people. They're usually able to walk a little quicker than people who take their own tissue, have less pain, things like that, maybe even a little less swelling. The disadvantage, unfortunately, is that this tends to have a little higher re-rupture rate. Now, the importance of who gets the allograft, that's what we have to pay attention to. If you are somebody who's in your early 30s and plays really high semi-pro competitive soccer, maybe this is not an option for you. But if you're that person who like, yeah, I can reconsider my options. Like, I don't have to play soccer every day. I don't have to play soccer. Maybe I'm okay with just playing it once a month. So the disadvantage is it tends to be higher re-rupture rate. There's been a lot of reason why, of course, like this tissue might not be able to withstand a lot of higher level sport activity. The other thing is that its ability to stretch, which we have seen that sometimes that causes failure in the graft. Really good option for people, in their 50s, 60s. I've seen plenty of ACLers who are in their 50s and 60s and who do wonderfully with this graft. Again, it depends on the type of person that's going through this, but also considering what you're wanting to return back to. But for an everyday person who, chases their kiddos around from time to time, like this is a good option. The other thing to consider in the rehab process is that, we just have to be diligent in how we load because, of course, the risk for the stretching in the graft. Now let's move on to autograft. Autograft is using your own tissue, so using your own tendon. And most often this is something that a lot of people do, especially younger people. So the autograft is using your own tissue, and typically we have the patellar tendon, the quad tendon, the hamstring tendon are the main ones that we typically see. Now we're going to start with the patellar tendon. The patellar tendon is gold standard. It is taken from, and I will show you, it is taken from, it is taken from this area right here. And that is your patellar tendon. So basically it's the tendon that is connecting the bottom of your kneecap to the shin bone, the tibia. This is the gold standard. This has been around for many, many years and has done wonderfully in terms of research. And it is a very strong, very good graft option. Now we have to consider who is having surgery, okay? Oftentimes surgeons will not do these in young kiddos who still have their growth plates open. They need to have closed growth plates to be able to do this type of graft. The reason is because it can compromise the growth plate, which might compromise their growth. So a lot of times people who are maybe 12, 13, you'll see a lot of surgeons shy away from the patella tendon option just because someone might not be done growing yet. And there's risk for causing issue to the growth plate. So the unique thing about the patella tendon is that you've got this thick tendon. What most surgeons do will take a piece of it out of the direct center, and then they'll go through and also take out some pieces of bone to create what are called bone plugs to help really secure the tendon in its new placement where the ACL was, to create its new ACL. The bone plugs help secure it. So the great thing about this is this is where it adds a little bit reinforcement, and usually it takes about 6 to 8 weeks for the bone to really heal, which is where we start seeing some changes happen inside the knee. The great thing about this is it tends to, advantages, it tends to have a lower re-tear rate, which is great. The disadvantage is that, unfortunately, early on, this is probably one of the most brutal early recoveries, just because you take the bone, but you also take piece of the tendon. And there's just a lot of trauma initially that there has to be a lot of early recovery to happen. So a lot of people will tend to have pain and a lot more swelling in the early phase because of that. There is, unfortunately, the risk of having, that 20 to 40% risk of having front knee pain after the 6-month mark. The nice thing is that this will eventually dissipate as long as it's managed well, and you're not causing further irritation down the road. But really good option. The hamstring tendon has been around for a very long time as well. It's one that surgeons used to do quite often. So what they'll tend to do is take the two hamstring tendons called the semitendinosus and the gracilis. Portions of those tendons will be used, and they usually do what's called a quadruple loop. Loop it in really nicely so it's nice and snug inside the tunnel. The advantages of this is that early on in your early phase of recovery, there's just less soreness or less irritability in the knee, like the patella tendon. Unfortunately, one of the disadvantages is that, of course, when you try to go and sneak into getting it or achieving leg extension, sometimes this can be a problem, because sometimes people get what we call graft site pain and can cause discomfort along where they harvested some of that tendon. This has about a 1.6 times higher re-rupture rate. So often we do see people with a hamstring tendon sometimes have that risk of higher re-rupture rate. Some surgeons back in the day, and even some today, will do another procedure called the LAT procedure to help reinforce it. We will get into that in just a little bit. The other thing is that regaining hamstring strength and even trying to achieve that full deep knee bend is very hard. And it takes a very specific program to really make sure that we're putting attention to detail and making sure that the hamstring is not, it's not subpar, and we want it to where it really needs to be. Going through, the next one is quad tendon. Quad tendon has shown great promise. It often, any surgeon will typically do most ACL graft types. It just depends on what they favor more. Some will do more hamstrings, some will do quads, some will do all of them, some will do what you want them to do. So the advantages of the quad tendon, so clearly the quad is in the front of your knee. The tendon is what inserts at the top of the kneecap, and it's a nice, very thick tendon. So it's a very good option, it's about 80% stronger than what your native ACL was originally, and it's a very resilient graft option. The other advantage is, of course, early on in recovery, pain is pretty low because there's some trauma, but not as extensive as the patella tendon. So we don't see a whole lot of people have quite a bit of pain with this. The disadvantage. The most important thing in ACL rehab is the quad. When you go in to have surgery, they have what's called a nerve block. And they tend to block what's called the femoral nerve, which supplies the muscle's ability to contract, specifically the quad,